find a chair? Or?
Yeah, come here.
Emmanuel. Thank you all speakers for joining us. There are a couple of questions that are general in nature. There are others that are specific to speakers. We do not have a lot of time, I fear, and it has been a long day. So may I request all speakers to be brief with their responses. Where is the Spanish question? So shall I start with this? This is a general question, not to a specific speaker. Well, it is not really a question, it's more like a statement, a contribution to the question on how a caregiver can identify the spiritual needs of a patient. The person who wrote this gives an answer. The physician, nurse or caregiver does not need directly to respond to the spiritual needs, but needs to acknowledge the presence of the chaplain or spiritual assistant as an essential part of the healthcare team. To facilitate access to that care and involve spiritual assistance in that care, decisions especially when facing conflicts and dilemmas in ethical issues. Dr. Philip Larkin, I don't know if you...
I'm here.
Sorry.
Can
I may have a point to add after you have responded, but would you like to have a go first?
Thank you very much. I mean, I'm going to say I agree with the statement and I disagree with the statement. I think it's important that we do acknowledge the contribution of the spiritual caregiver within the team. And I think, unfortunately, to some degree, they have been, the English phrase would be the poor relation. So they've been there, but often their role has never been clearly defined within the function of a multidisciplinary team. But I also feel very strongly that we each have within us the capacity to respond to the spiritual need of the patient. Whatever that need is, knowing how and where we get the resource and support from the professional spiritual caregiver when we need that. But in my experience, I'm a nurse. I've worked as a nurse for 30 plus years. The time that actually the deepest spiritual questions come up is usually at 3 o'clock in the morning. For most nurses, they will tell you that's when they deal with those deep issues. What I need to know is I have an understanding of how to address that, to listen to what's being said, but then to also ask the advice of my spiritual expert, how could I make that better? And so although I absolutely agree, and I think that the spiritual professional has specific skills which we need to develop in palliative care, I wouldn't want to lose the fact that there are very, very good skills within all the members of the team. Because if you leave it to one individual, I fear the risk is that when the spiritual comes up, it gets lost.
Thank you. We will be going into more issues regarding spirituality in the multi-religious context tomorrow. So maybe we can stop there with this one. Here is another question. This morning it was said that palliative care needs are different for children and so on. Why was it said that palliative care needs are different for LGBT? Is there scientific evidence that lesbians or homosexuals need a different approach? If yes, why? In a scientific point of view. Would somebody like to take that question? Yeah. Would you like to? Well, maybe to be brief, I would think or we think, I am sure, that palliative care is not only physical care and treatment of symptoms, and if we accept that it's also related to social, psychological, and spiritual issues, it's fairly clear that the social issues that affect an LGBT person the social issues are different. And it is different from country to country. So at least in that context, their ability to access treatment, the way the society responds to them, very clearly that would need understanding their problems from their point of view and responding appropriately. Still one more for you. Sanya. Emmanuel, would you like a brief response to that question?
This one?
There was this one.
Okay. I have a question which where somebody is asking why Cameroon in West Africa is excluded in the lists that I showed. If you go to the countries that I showed were mainly the top countries in terms of whatever area I was focusing on. But if you go to our website, you'll see the full atlas that was produced, and you'll get information about Cameroon. Having said that, we have a dilemma in Africa which we need to address, that much of the palliative care development is mainly in Anglophone countries, especially in East and Southern Africa. West Africa and Francophone Africa and Portuguese-speaking Africa, a lot has to be done for them to catch up with Southern and Eastern Africa, irrespective of the fact that even Eastern and Southern Africa, their progress is really relative. We are talking about comparing dwarfs and saying this one is shorter than the other. But we are all dwarfed by the burden that we have in Africa. So Cameroon was not on the list that I mentioned, but it's in the whole list that we have in the atlas. Just to confirm that all is not well as regards access to palliative care in Africa, Cameroon included. I hope I've answered that question.
Thank you, Manuel. We will go on to the next question. Apologies for hurrying, but because we have to finish at 6:30. Dr. Azza, you have 3 questions there. Would you like to take the first one, please? Any one of them to start with?
The first one is about the mortality rate in the palliative care section. 85% among our patients referred to the palliative care in Qatar, they are expired in the unit. And the rationale behind that is that we don't have a home care program to take care. Still the home care program taking care of non-malignant condition. So the nurses, they have no skills to take care, and they are afraid to take care for that. And we have proposal for the palliative care program to start a specialized palliative care program for the oncology patient. We don't have hospice till now, so the discharge of the patient to the community is still the family, they are afraid to care for the patient at home. And also another point from the culture point of view, the family preferred the hospital to be cared because they consider that this is the most they provide to the loved one at the end. This is another reason also.
Maybe there are many issues there to be discussed, but this evening we simply do not have the time. Tanya, would you like to go to one of your questions first?
I'll answer both questions in once, if you want.
Very good.
Well, I have 2 questions. Is the difference in countries with similar incomes, and why are so different the conditions? And I spoke about Costa Rica and the Dominican Republic, and I think there are some key issues in both countries. For example, in Costa Rica, there is a huge volunteer movement, a huge community movement, and it's make that palliative care grows very quickly in Costa Rica, and they have a wonderful law, and it's the caregivers law, which pay the people who are caring patients at home the salary that they got at least for 6 months. It's different. Well, so that they improve very much the caring at home, which is decrease the cost in the hospitals. They work with a very good network between hospitals and hospice and domiciliary care, also the primary care. And I think there are the reason why they have a very good educational issue. They have a specialization in palliative care, which is not in all Latin America. Well, I think it's the combination between politics, community, and palliative care workers, which makes the condition in Costa Rica are so great. And the other question is, how can we, in the other countries, to work in palliative care in these conditions? Well, I have to say, I have to speak about the poverty, and it's incredible how my colleagues in Latin America are able to work under these conditions, and palliative care there is in all countries in Latin America, in some kind, as Honduras had 4 medical doctors, but they work under these conditions, and they can show a lot of improvement in the quality of life of the patient and the families, as I show you, under these conditions. But of course, we need improvement of all that, of medication, of education, of more services, and with a very good policy of health policy of health. But it is really wonderful how my colleagues can achieve really change or really make a difference under these conditions.
Thank you. Daniele, you have a comment to add to that? You look as if you have something to add. No?
I think we are just
okay.
to hear the speakers. The time is really short, so thank you very much.
Sister Jensen Young, you have a question from an admirer saying it was an inspiring talk and adding on a question.
Yeah, I have a few questions. Actually, this Holy Name meditation program based on the East Warren's book, 8-point program. 8-point EPP is 8-point program, and I mean we modified it from the book, and we have a multidisciplinary team in our team. Like we have priests, we have several people belong to my spirituality team. So when we develop this program, we read the book, and then we make adjust it into our culture. So, and in the beginning, we tried to eat the nurses, and it has really effects. So I modified it to the cancer patient, and then it also affects. And somebody asked me, how about morphine? I don't touch any medicine. Since I'm a nurse and professor, I just use it as a complementary therapy, so, and self-care. So I don't touch any medicine. Yeah. But sometimes patient has effects with this program, and reduce their pain too. And so, yeah, that is my answer. Is it enough?
Sister, I have a question. I fear I did not quite understand about the last point. Did you say that your patients would not be accessing morphine through you? I mean, like, if somebody is in pain, Is their pain addressed only spiritually? There is no pharmacological treatment?
In the beginning, we need to control the physical pain first. So, yeah. After controlling physical pain, we can approach it. Yeah.
Thank you. Catherine, did you have a question with you? Catherine?
Thank you. I have a question that I don't quite understand. It says, what is the point with narcotic drugs? The point is that, if I understand the question, is that the laws that govern narcotic drugs, the international conventions that govern the use, the medical use and non-medical use of narcotic drugs, it's the same law. And the language stigmatizes the non-medical use and criminalizes in the non-medical use. And the convention did not give countries explicit directions about how to make opioids available for medical use, whereas it did give them explicit directions about how to criminalize non-medical use. So it really overemphasized misuse and recreational use, although it didn't use those terms, those are modern. And it did not give explicit directions to countries about how to make medical use rationally available for patients. Again, this was pre-palliative care, and since then, many other pieces of the pallium have developed, but narcotic drugs are stigmatized. We all know that. Raj certainly knows it.
Thank you, Catherine. Absolutely, I totally agree. Dr. Rasa, you have another question waiting there. Don't you have another question?
Another one, what do you think about foster the inpatient palliative care unit more than spread of the palliative care, or query, or should be low technology or low budget palliative care be developed first? I don't understand the questions well, but I would like to go with the palliative care in services. For sure, for every country should do estimation and to assess the needs and how they can start the palliative care service. Palliative care service is very important, but how the model can be different from one country to another country. It can be consultation, can be inpatient, can be outpatient clinic, can be home care only. And this is according to the gap assessment and the resources available for each country.
Thank you. Even if all the questions are not addressed, I hope the person who submitted the question will bear with us. We will have to close with the next one. Dr. Phil, you have a question there.
Yeah, I think there we are, very quickly. So I have a question in Italian, so I hope I've translated this properly. But the question is asking, really, to what extent can anthropology, which looks obviously at culture, how can that influence and look at palliative care? And I think one of the areas in which anthropology, and in fact I've worked with an anthropologist in a palliative care team, is very much looking at the context of transition in culture. So there's a lot of work written by famous authors from the 20s and 30s on, for example, Arnold von Gennep and Victor Turner, that look at the context of transition and how people transition through society. And if you relate that to palliative care, we see our patients transition from living to dying. And Victor Turner specifically points about a context called the limina, which is a special place that happens when things transform. And I think many times in palliative care we work in this liminal space because we're part of something quite different, unique for the person because it's their dying, and we work alongside them, watching what happens to them in this liminal space as they come to terms with their dying, as they understand what's happening, as they do the things they need to do. So I think that anthropology as a concept, as a study, has a lot to offer us in our understanding of what palliative care is.
Daniela, would you like to make your closing remarks?
So, thank you to all our speakers, and thank you to all of you being patient and being together with us till the end of the session. I think it was a very diverse, and I think it gave a very broad view what is happening in the world and how diverse the problems are, but still how creative people in this area are in finding solutions and in moving the field forward and in speaking the right language for their own situation. Might it be research, might it be advocacy, might it be education, might it be looking at ourselves. And I think we all are enriched by and have heard about Rays of Hope from all the services coming from here. So thank you very much and see you tomorrow.
Ci vediamo domani. Buona serata a tutti. La sessione inizierà domani mattina alle ore 9.